It's the PainExam podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back, and it's currently June 4th. Have ASPN coming up next month. Going to be teaching ultrasound there. Hope to see you there. Then Pain Week in September, and of course Latin American Pain Society, nice New York, New Jersey Pain Conference, and many more great conferences. I do have ultrasound courses, so if you're interested in coming, check out nrapain.org. Go to the course page, and these are CME ultrasound courses. I'm still toying with the idea of another regenerative medicine course, which might be in the fall or winter. I'm also doing the private training as well for those of you who want some more intense ultrasound training. Anyway, it's board prep season, and this year I'm doing something very different. It's not really that unique these days to have a community, but we decided to put a community page on the nrapain.org website, and if you are registered, even if you didn't pay anything, you should have access to this community where people are going to post free information, which I think is probably the only place I would imagine that you could probably get tidbits and keywords for the boards. Once again, please do not post any remembered questions because that's a big no-no, and I'm not in the interest of alienating the medical societies giving the board examinations. In fact, I'm a board question writer. I've written questions for various pain boards, so I want to stay on their good side. So only put remembered keywords. You can mention that they asked about phenol or dosing or this or that. So, and that's one of the items that was already posted, and that led me to today's podcast, which is a Journal Club article on the low-volume neurolytic retrocrural celiac plexus block for visceral cancer pain, a retrospective review of 507 patients with severe malignancy-related to pain due to primary abdominal cancer or metastatic diseases. This is by Dr. Rahman and Dr. Macronici and Dr. Lee. It's a nice article. And basically, I'm going to summarize it from the abstract. Abdominal pain from the primary care or metastatic disease is a significant cause of pain for patients undergoing treatment for the disease. Patients' pain may be resistant to conventional analgesics. The need for timely pain relief in order to facilitate further care in the cancer treatment plan should be a priority. The objective was to assess relief given, and this was a retrospective observational review, by the way, with low-volume neurolytic retrocrural celiac plexus block, the duration of the procedure, the duration of relief, the reduction in daily opioid consumption, and the improvement of quality of life in patients suffering from incapacitating abdominal pain due to primary abdominal malignancy or abdominal metastatic disease. Patients were given a neurolytic celiac plexus block without previous diagnostic block due to multiple comorbidities. And by the way, just as an aside, I understand that. I mean, normally we want to do a diagnostic block anytime you do something neurolytic because theoretically there's a higher risk with neurolysis, and you don't want to do that, expose the patient to that risk for nothing. But when you have patients who are very sick, it may be hard to time the stopping of their blood thinners or for various other reasons, and they're dying and they're in pain, it may be worth the risk of just doing the block without a diagnostic. So I do understand that. Just as another aside, I trained on doing the transaortic celiac plexus block, which is a procedure we would do after making sure there was no plaques or aneurysms in the aorta. You don't want to mess with an aorta if there's any risk of causing it to rupture. And we would do a transarterial stick through the aorta, get bright red blood, then go out through the other side and give our medication. And believe it or not, this was a pretty safe effective way of doing things. Kind of terrifying if you think about sticking a needle through the aorta, but it worked really well, and I never saw a complication given. I've only done a handful, and I don't really do them much these days as an outpatient pain doctor mainly. Anyway, the methods of the study: 507 patients were studied, and the data at 5 months for 455 patients was retained at the end of the review. They were evaluated in the pain center prior to and after the neurolytic retrocrural celiac plexus block under fluoroscopic guidance. They were assessed on duration of procedure, pain scores, numeric 0 to 10, daily opioid consumption, quality of life improvement, simple yes or no questions at 3 months, and routine follow-up during treatment for cancer for 6 months or end of life. All data was gathered by extensive chart review and placed on a spreadsheet for analysis. Follow-up was completed 6 months after the procedure. Pain scores, daily opioid consumption, and quality of life showed improvement for the duration of the study. There was some return in pain during the 4th to 6th month due to disease progression and the anticipated duration of the neurolytic agent. Some short duration known side effects did occur. An initial vascular contrast uptake of 6.7% was noted during the procedure while using digital subtraction angiography with fluoroscopy. The limitations they mentioned: a larger sample size would be ideal, as well as prospective trial with a control group. But it's unrealistic because of the population. A proven quality of life questionnaire would be beneficial. They also say that comparing alcohol, phenol, and RF thermocoagulation would be interesting to equate duration effects and side effects. Yes, there are some people who just do RFA splanchnic nerve at T11. I think it's T11. I haven't done that in a while. But anyway, they concluded that low-volume neurolytic retrocrural celiac plexus block with phenol is safe, providing up to 6 months of pain relief, and is an effective, well-established, minimally time-consuming procedure for abdominal pain due to primary malignancy and or metastatic spread. So, what is low volume? Well, let's look into the article and see a little more. By the way, there are some really nice pictures of the way they did the procedure. If you're not familiar with the block, I highly suggest that you look at this. And in terms of the actual procedure, the patient's the retrocrural celiac plexus was targeted at the level of L1 with the aim towards T12, so they're aiming upwards. Anterior and posterior radiographic imaging aligning the spinous process of T12 and L1 junction was used, along with 15 to 20 degree oblique rotation and cephalad orientation to move the transverse process from the center of the vertebral body. Local anesthetic, lidocaine 1% with sodium bicarb infiltration along the injection direction was performed. The bicarb can take the sting out of it and also hasten onset. The anesthetic of choice was started with the patient remaining communicative and responses deemed appropriate during the injection of the local test dose and neurolytic portion. A 22 gauge or 25 gauge 3.5 inch to 7 inch curved spinal needle was used depending on the patient's body habits. I usually go with the 6-inch Chiba for something like this, but I've definitely used a 25 gauge spinal needle. It was advanced until the periosteal surface of the L1 vertebral body contacted using multiple AP lateral and oblique views. In the lateral view, the spinal needle was advanced to the anterior border of T12L1. Contrast dye studies were done to verify spread and location. No air bubbles in the extension tubing were present, blah, blah, blah. Digital subtraction angiography was used to verify any intravascular uptake, or abnormal spread patterns. A test dose of 1 ml of 0.5% bupivacaine with epinephrine per site was given. I find that interesting. I never really mix bupivacaine with epinephrine, usually lidocaine. But anyway, there was no signs of vascular uptake. 3 to 5 mLs of 6% aqueous phenol was injected in 1 ml aliquots while speaking to the patient, and the needle was removed after being flushed with local anesthetic. The average procedure time was 16.3 minutes, which is pretty good. With minimal anesthetic or no sedation, patient was communicative throughout and then would be placed prone for 30 minutes to avoid neuroforaminal spread. So, right, phenol, is more heavier and viscous than alcohol, and if you put the patient prone, it's going to sink down and stay away from the foramen, which makes sense. Patients were monitored in the recovery for 1 hour for adverse events. the ability to eat and void easily. They were discharged once hospital post-anesthetic criteria was met, and they had received a phone call 24 hours after. So I think this was a really nice study. If you look at the pictures here, it looks basically like a lumbar sympathetic plexus block, or any sympathetic plexus, which it is. It is a sympathetic block. You're at the anterior lateral border, it looks like. Here, I have just, because I'm like really a crazy ultrasound guy, and I fantasized about doing an ultrasound guide celiac plexus block, but of course you have to worry about bowel. I did talk to one of my interventional radiology colleagues who suggested I just go transhepatic. I believe somebody's done that somewhere. I haven't. If any of you guys have done that, I'd love to hear about your experience. I remember scanning a very skinny patient, and the aorta was seriously like less than an inch or 2 inches away from the anterior abdominal wall in this patient. Maybe I'm exaggerating, maybe 2 inches or 3 inches. But it was such a simple thing to see, and if you understand where the plexus is, the celiac plexus, you could just get there without harming bowel, causing bleeding from the liver or any other pathology or gallbladder perforation, I suppose. It would be a very quick and easy thing to do. But I did have a patient in the office with some severe pancreatitis pain, and we did do a paravertebral thoracic nerve block. I think it was the level of T8, T10. And they did get temporary relief, given it was not neurolytic. But they did get relief, and they walked out of the office feeling better. So there is something to all these nerve blocks, and the paravertebral blocks do have some sympathetic spread. I like paravertebral because you're getting the exiting nerve root, you're getting the medial branch, and you're getting those nerves that contribute to the sympathetic chain or splanchnic chain. So you can really do some good. Anyway, this article, check it out. It's a really well-written, nice study, and you could see the graphs with the morphine consumptions dropping over the course of a few months after the procedure. It's definitely underutilized because I think people who just don't do neurolysis don't want to do neurolysis because it just sounds scary, and it could be, of course, if you paralyze somebody or you hurt them. So this is... Once again, I encourage you guys, check out this community I created. It's got separate chat rooms, one for the regenerative medicine, regional anesthesia, and the pain boards. And you could create your own one, or you could email me. I'll create it if you want one for anesthesia board prep or some other area where you guys could trade information. If you took the boards, feel free to post keywords. Do not post questions. Once again, I don't want any problems. So just say, hey, know this for the boards. No alcohol versus phenol, which they could always ask, especially on the anesthesia boards, etc. So thanks for listening. Please check out the nrapain.org or PainExam website, which is basically the same thing these days. And we have the CME course calendar, next ultrasound course in New York in July, then another one in October, and maybe something in between, who knows. But we do have the private sessions. Actually, tonight, I don't think you'll get this by tonight, I'm doing a PRP lecture for SOMI docs. They're having an online pain conference where it's a preview of my Pain Week talk, where I'm going over many of these same studies and techniques for treating pain with platelet-rich plasma. Anyway, I appreciate you. Thanks for listening. If you like the podcast, please give us a 5-star review and share it with your colleagues. Have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.